Yes, sir. We are live on YouTube. Welcome to the Indian Arthroscopy Society webinar series as a part of Academic Corner for the month of February. Today we have with us Dr. Amarnath from Telangana and Dr. Prathamesh Jain sir from Gujarat as moderators for this webinar. I would like to hand over this month's webinar proceedings to Dr. Prathamesh sir and Dr. Amarnath. Over to you, sir. Please go ahead.
So, warm welcome to all the guests. I would just not take much time, and I'll start straight away the agenda. So, I think Raghavendra can present his case of the hip arthroscopy. I think assisted AVN.
Yes.
Please go ahead, Raghav.
Okay. You can see my screen.
Yes, sir. Make it into
Okay.
slideshow.
Am I audible?
Yes, you are audible.
Yes. Okay. Thank you, IAS once again, and Dr. Naresh for this for this opportunity to give a talk on this arthroscopic assisted co-decompression of a femur lead. I find this quite controversial because a lot of seniors of mine or colleagues, they keep asking me why I do arthroscopy for AVN. So
Sir,
here,
make it into slideshow. Sorry, make it into slideshow, please.
Okay. Is it okay now?
No.
No, sir. Yes, okay, sir.
Right, okay. So they do keep asking me that why I keep doing hip arthroscopy for AVN. So here is my justification for their queries. So I'll be talking on AVN of a femur lead arthroscopic assisted co-decompression. So we all know that AVN of a femoral head is a loss or interruption of the blood supply to the femoral head. There are multiple factors involved in AVN of the femoral head, starting from genetic to multifactorial. Important risk factors include chronic long-term use of corticosteroids, and COVID. After COVID, we have a lot of patients with AVN of femoral head, especially, and other risk factors involve chronic alcoholism, trauma, EPI, hypercoagulable states, and other causes like sickle cell anemia, SLE, inflammatory bowel disease, endocrine disorders, and HIV. So we are all familiar with FICAT staging starting from stage 0 to stage 4, but our focus is mainly on the pre-collapse here because post-collapse it is hardly salvageable. So our focus is mainly on the pre-collapse. We know that it is amenable to the preservation of hip. So the procedure is mainly co-decompression of the hip, and we add additional procedures with or without coding involving the other procedures like vascularized bone graft or non-vascularized bone graft, biological agents like bone marrow, bisphosphonates, or rotational osteotomy. But this talk is mainly on the arthroscopy or arthroscopic assisted co-decompression. So there are many literatures, even though not very severe numbers. We have very scarce of literatures in the arthroscopic assisted co-decompression, but whatever available literature we have, they all suggest that very good responses following the arthroscopic assisted surgeries. So there are multiple case reports or technical notes published in the literature, but probably these two literatures in 2020 and 23, which have a longest follow-up so far. One on the left side has 5-year follow-up, and one on the right side has long-term follow-up of 10 years. And they both conclude that it is a promising surgical approach, The main advantage of putting a scope in AVN is it allows the treatment of the concomitant intra-articular pathologies like FII, synovitis, chondral pathologies, labral tears. And there was one paper published in 2020 in Journal of Hip Preservation Surgery, which says that around 95% of their patients had associated hip pathologies, intra-articular. And hip arthroscopy also allows accurate drilling or the lesions, and it avoids undue penetration of our rim into the joint, and very good response in terms of mechanical symptoms alleviating. But the only problem with this technique is, or the procedure is, we have a scarce literature, as I mentioned. Now, here is an interesting concept published in 2023 by, again, China, in the Journal of Arthroplasty, which says that the basic principle of core decompression we do is to reduce the intra-articular pressure, intraosseous pressure. But they mentioned that after doing hip arthroscopy, it reduces the intra-articular pressures. So even though there are no parameters to assess the reduction of intra-articular pressure, but it makes sense. It is quite logical, or it looks quite clinical, because we are putting a scope, we are debriding the joint. It acts kind of a tamponade effect by reducing the intra-articular pressure. So both intraosseous pressure reduction and intra-articular pressure reduction in turn increases the blood flow. That was their observation. So my series, I'll be talking about my series. I have done around 12 hips, 10 patients, 2 patients were bilateral, and there were 9 male and 1 female patients. I included almost majority of the patients pre-collapse, and 1 patient, 3 hips were post-collapse. I'll tell you shortly why I included the 3 patients. And age group was around 12 to 45 years. And I have a longish follow-up of 5.5 years, 5.5 years, and shortest of 6 weeks, which I done in a anesthetist. So, and almost all patients I found coexistent hip pathologies. The technique I used is all the 3 techniques for joint entry. One is peripheral compartment first, the other one is central compartment first. And whatever the cases where I couldn't enter the peripheral compartment or central compartment due to tight hips or coxa profunda, I used outside encapsulotomy first. The position is same, which we use for regularly for hip arthroscopy, standard supine position and traction. But the only difference is the CM comes in between the legs so that we can take a lateral view during core decompression. Portals. For peripheral compartment first, I use 4 portals. One is proximal anterolateral portal, that's a Dean's portal. The second portal is anterior portal. Third portal is anterolateral portal, and the last portal is Dala. If at all I'm addressing the labrum. But here in my series, I didn't have any patients with a labral tear or chondrolabral suppression, but I did use for rim trimming in a couple of patients. And for peripheral central compartment first and outside in capsulotomy first technique, two portals basically. One is anterolateral portal, the other one is instrument portals, that's anterior portal. How I did core decompression, majority of the patients I did like traditional retrograde rimming with the 6 mm, and a couple of patients I used multiple drill holes, which was mentioned in the one study again, where I used 1.8 mm drill bits for core decompression. Now, what are the advantages we have in arthroscopy? So one major advantage is addressing the synovitis. So almost all patients in my study had synovitis, and this is one important study again from China, where they have done hip arthroscopy for in AVN of around 185 patients, and in 85%, that's around 157 patients, they found a coexistent or concomitant synovitis. So by addressing this synovitis, we can definitely reduce intra-articular pressure. Here, This is one of my patients. So as soon as I put a scope, angry looking joint, quite gross synovitis. So this is a peripheral compartment first. So head below, the labrum on the upper side. So it's quite difficult for this joint to enter. So we can imagine the amount of pain relief a patient might have after doing this synovectomy. So first thing I did was to do a capsular thinning and do a proper thorough synovectomy. So this is a peripheral compartment first. I use a shaver from the anterior portal and scope in the proximal anterior portal. So I spent a lot of time in doing the debridement here, doing synovectomy, and with this, there was a quite a relief of symptoms patient had after surgery right from day one. Now, there will be some difficult conditions as I mentioned before, tight hips, coxa profunda, or the thick capsules following the uncontrolled diabetes. So this is one of my patient who had a very thick capsule. So I couldn't use the central compartment first or peripheral compartment first here. So I had to use the outside in capsulotomy first. So entering the joint from, I'll just stop here, entering the joint from outside in, from the capsule to interior of the joint. So as I did the capsulotomy, so as you can see, the sinum already protruding out. So proceeding further, doing a liberal capsulectomy, rather not the capsulotomy, capsulectomy, so as to relieve the tension, and which helps in the entering the joint. So we can already see the head being exposed and the labrum above. So what are the other advantages? So after synovectomy, we can address the head. So almost all patients had a similar head in this study. So this is a positive Ballottement test. You can see the head being really soft, and I put a probe. It really sinks in. That's a positive Ballottement test. So, but here the contour is maintained in one of the patient, but here in one of the pediatric patient, as we can see, though Ballottement, I can see the Ballottement, but the contour is lost here. It is flat, but however, the cartilage cap is intact. So that flattening is due to subchondral collapse. Moving forward, so what are the other advantages? So we can assess the labrum in all the patients. None of my patients had a labral tear or contralabral suppression, so I didn't have to do a labral repair here. I just had to do a labral debridement in one of the patient where he had a labral calcification. I'll show you next. So this is one of the patient. So again, positive Ballottement, and I turned the probe to check for the labrum. Here, fortunately, the contralabral junction was intact, so I didn't do anything for the labrum here. So this is the next important issues where we can address the arthroscopically, so addressing the FII. So one of couple of patients had CAM impingement, positive impingement, that's positive flexion adduction internal rotation test. So I had to do as you can see in the X-rays above. So I had to do a CAM osteoplasty, regular CAM osteoplasty, starting from anteromedial, moving gradually to anterior, anterolateral, and lateral. So as you can see, I'll just go back again. As you can see, the bone is really soft here in the anteromedial or anterior aspect. But as you go gradually laterally, the bone gets sclerotic. So I had to do a good CAM osteoplasty to relieve the impingement symptoms. So it is another patient of mine, pediatric patient. So he had a CAM impingement as well. So I had to do a CAM osteoplasty, and you can see here underneath the physis being exposed here. So it really gives a good pain relief following the surgery when we do a CAM osteoplasty. So another important, along with the cam, we can address the pincer also. Sorry, we can address the pincer also. So you can see in the picture here, he had a bilateral AVN left side. I operated. He had a global over coverage as well, coxa profunda. So I had to do a rim trimming. Fortunately, here again there was no controllable suppression. So that was a labrum. So I used a shaver first to do a capsular thinning and use a reamer burr to do a rim trimming. So this was a pincer resection which we can address arthroscopically in case of AVN as well. So now next important aspect is addressing the caudal. We can address the caudal defects or the loose bodies as well. So in one of the patient had mechanical symptoms. So as we can see in the video here, the cartilage being flapped into the joint in the stapler fossa, and that was giving him mechanical symptoms. So I had to take out this contral flap, debride it, completely resect it, and this part of the head where there was a defect, I did microfracture, and patient really did well because he had a lot of mechanical symptoms of trauma with a pre-existent AVN, and it completely relieved his mechanical pain after this resection. In another patient, I had this chondral defect, as you can see in the video here, and there was also chondral flap. So I had to do a thorough debridement here. And same patient, which I had shown previously, had a thick capsule. So I had to enter the joint from outside in capsulotomy technique. So here we can see the chondral defect on the head, and the rim hardly has any labrum. So fortunately for me, I didn't have to worry about the labrum because there was no labrum here. Now, how do I do a core decompression? Ideally, arthroscopically, we can use, this is not my images published in one of the literatures. They have a long jig where they can put jig in the chondral defect and they aim right at the lesions. Unfortunately, we don't have this aiming guide or jig in India. So I use only standard core decompression technique, which we use regularly, freehand technique, entering from the GT and passing the reamers, 6 mm reamers. So most of the patient I used this, but in one of the patient, I used a small hole multiple drill technique, which was published in one of the arthroscopic techniques, where they use 1.5 or 1.58 mm drill bit to make a multiple drill holes around 5 to 10 in number, with a scope in anterior anterolateral portal and drill bit from the anterior portal. So I used one of the same technique in one of the patients. So this was drill holes I made in the superolateral part of the head and neck junction. And fortunately, after relieving the pump pressure, so this was a bleeding I get. So this patient I had around a 3-year follow-up, though he has a minimal, not completely off symptoms, but he is bearable. 3-year follow-up now, but he is not ready for THR8. Now, these are few results. I'm not going to talk about all my results. Few patients I'll talk about my results. So this is one of my patient, pediatric, 15-year-old, bilateral AVN, steroid induced. I have a 3-year follow-up of this. So he had a cam impingement, and patient was quite symptomatic before surgery, as we can see in the video. Very painful hip. All the movements globally were painful because of the associated synovitis and impingement. So rotations were painful as well. Now, after arthroscopic assisted coding of decompression and cam osteoplasty, now this is how he walks. He walks a bit of a waddling, but absolutely there is no pain involved. Now, this is another patient of mine, 19-year-old, again steroid-induced AVN of left hip. I have 1-year follow-up, and we can see impingement is positive, flexion, adduction, internal rotation, and this is the X-ray. and he had a small cam deformity, so I had to do a cam osteoplasty and arthroscopic assisted co-decompression. Now this 1 year follow-up now, he is again walking pain-free. Now this is the one case which really surprised me a lot. As you can see in the picture, completely post-collapse, stage grade 3 on the both side, again steroid induced. And he had a multiple vertebral collapse at the same time, got fixed somewhere else. He was completely non-ambulant, almost bedridden because of the paraparesis, and he had a bilateral involvement of the hip as well. So I did co-decompression on the both sides, arthroscopic assisted, but on the right side, after 1 year, because of the persistent pain, I had to convert into THR. But on the left side, it's still 5.5 years. He is absolutely, he doesn't want to undergo any replacement here. So this is the video he sent me a couple of days ago from his native town. And you can see, in fact, he has a short-limbed gait on the replacement side. He is walking with a short-limbed gait, but on the left side, it's 5.5 years. Even in stage 3, with the collapse, he doesn't have any pain. So to conclude, arthroscopic assisted co-decompression is excellent and efficacious. The very advantage of this putting a scope and debriding the joint is it gives immediate significant pain relief, unlike where we do isolated co-decompression, because we are addressing a lot of concomitant hip pathologies, and we can directly visualize the femur head for co-decompression. And there is a quite doubt on whether we can really intra-articular, it does reduce the intra-articular pressure, but logically thinking it should reduce because we are debriding the joint completely, so it should act as a tamponade. And but the big question mark is whether the head viability or the purpose for which we are doing the co-decompression. Do we have any study whether where it is compared that arthroscopic assisted co-decompression has a better head viability than standard co-decompression? We don't have any studies yet. Thank you.
Excellent presentation, Dr. Raghav. I just have one question for you. Can you hear me?
Yes, I can hear you.
So you have very nicely described about two techniques of co-decompression, the standard technique and the arthroscopic assisted micro drilling from the top. Yeah. So what is your preference nowadays? What do you prefer? You prefer drilling through the neck, or you prefer drilling directly nowadays?
I would prefer with a standard co-decompression like 6 mm, like regular. Yes, that gives a wider canal and more chances of addressing the lesion.
Because the proponents of the direct drilling from the arthroscopic drilling, they say that if you do a direct drilling, you are avoiding the drilling through the neck, and that way you can mobilize this patient faster and you can mobilize the patient next day. What is your rehab protocol if you are using if you are drilling through the neck?
Yeah, just a slight difference. The standard one, I put them at 6 weeks non-net bearing.
Yes.
The other one, maybe I'll start now limited, like 3 to 4 weeks, because the tunnel diameter is less.
Yes. So I think it will be a nice thing to study comparative outcomes of both the co-decompression, the micro drilling from the hip arthroscopy, and drilling through the neck. And I think that should be the way forward for the hip arthroscopic assisted co-decompression.
Yeah, we need a largest cohort study or a comparative study, but
yes.
Yeah, I think it is completely lacking in the available literature. Probably we should conduct that.
Perfect. Very nice presentation. Excellent. Enjoy.
I have a small question, sir.
Yeah, Dr. Amrar.
Yeah, in your hip arthroscopic, you have seen in some of the femoral heads there was a softening of the cartilage.
Yes.
That is Ballatman test positive. After doing co-decompression, anyhow we are removing the subchondral bone. As the cartilage is soft, is there any chances of further collapse or immediate collapse post-op?
There were no immediate collapse as such.
Why? Because we are removing the subchondral sclerotic bone, and
Yeah.
as well as there is a ballotment in the femoral head now.
Yeah.
By doing core decompression, we are removing that bone, and we are removing the support which is there underneath the cartilage.
Yeah.
In such cases, there is any aggravated collapse following a core
No,
decompression?
I have not seen any aggravated collapse because we put them anyway on non-bleeding for a few weeks. By the time that should revascularize and give a good support. Our aim, the whole purpose of doing core decompression is to prevent the progression of the disease, going into the subchondral collapse from pre-collapse. That should not. In case of pre-collapse, they should not happen, but already collapsed, we cannot comment on that.
Regarding coming to the COVID avians, they are rapidly progressing. Whether we are in some studies, they are telling even if you do core decompression, that it is not preventing the collapse, and further progression to a stage 3 or stage 4 are rapid. How are your studies, sir, when you are doing arthroscopic assisted? How you feel different from the regular avian in these cases?
I'll tell you
Because
very
you are
frankly.
seeing from the joint side as well as from the hood side.
Yeah, I'll tell you very frankly.
Yeah.
So arthroscopy will only address the intra-articular pathologies.
Yeah.
There is no document to say that arthroscopic assisted core decompression will have a better, viable chances than the standard core decompression.
I'm not asking regarding the viability and all the things.
Yeah.
How is it is regularly different from the when you see regular avians and COVID avians in arthroscopy?
COVID avians.
Yeah.
COVID avians, nothing much. I mean, it's the same. I did 6 weeks ago. I did in one of the anesthetists. I mean, the findings were same. She had COVID, post steroid induced. I don't find any difference. It was almost the same like what we have in the steroid induced avians.
Okay, sir. Nice presentation, sir.
Thank you.
I have one question for you, sir.
Yeah, Tirtha.
In order to reduce intra-articular pressure, you said that you are doing a capsulectomy. So my question is, does it affect the suction cup mechanism of the hip and
No.
lead to kind of a micro stability?
No, suction effect is from the labrum, not from the capsule. When you are doing the capsulectomy, it acts as a tamponade. See, it's a closed chamber, right? With the capsule intact, it's a closed chamber. So it's like when you do a capsulotomy or the capsulectomy, it decompresses. It should decompress, thereby decreasing the pressure. But it doesn't have any effect on the stability or the suction effect. Suction effect is formed from the labrum, not from the capsule.
Okay, and what part of capsule you are excising, sir? Anterior, posterior?
Supralateral.
Supralateral. Okay. Thank you, sir.
Can we move on to next talk, sir? If everyone is clear.
Yes, Amarnath, please go ahead.
Yeah. Next talk is by Pradeep sir or Prahalad sir?
Prahalad sir.
Prahalad sir.
Stop sharing.
Now I welcome Dr. Prahalad Kumar Singhi from Madurai, Tamil Nadu on his talk on arthroscopic assisted proximal tibia fracture reduction. His case series he is going to present. Dr. Prahalad sir, can you?
Yeah. Good evening, everyone. Is it visible now? My screen?
Yes, sir.
Yes, sir.
Yes, visible.
Yeah. So, thank you, IAS, for giving this opportunity. Thanks, Naresh, Tirth, Sandeep. So, it's been long time to again be on this webinar. So, thank you again for reconnecting it. So, we had a nice talk by Raghavendra. So, the role of arthroscopy in hip avian. So that is the way we try to look forward. So this is again my topic where see, day in, day out, we are coming across, we are all trauma surgeons to begin with, and then we go into specialty. So definitely we are trying to extrapolate all these super specialties into our basic core trauma practice. So we all come across in our day-to-day practice these proximal tibia fractures, and we always try to focus on the fractures, but we tend to forget that we have these cruciates, collaterals, and meniscus, which do also influence the outcome if they are not identified and addressed at an appropriate time. So these can cause a disabling instability and arthritis. So there are various literatures which support this kind of concept, and they have shown that there is an increasing evidence of advantages of arthroscopic assisted fixation in these kind of surgical techniques, in these kind of fractures. And also they have shown that there is a significant amount of these injuries where you can see there is sorry, 1 second. Yeah. So you can see that there is significant incidence of collaterals and cruciates ligament associated with proximal tibia fractures. So we are all aware about these classifications. So we commonly follow the Shatzger's classification, and the first three types, we all know it is a valgus type of injury, and these are associated many of the times with MCL injury. So it is very important to identify these injuries. And if you see in the next type 4, 5, 6, they are more complex high velocity injuries, and there you can have associated cruciates and collateral ligament injuries. For me, this classification is very important, the Holmos classification, where these subtle fractures. So if you see the fracture dislocation pattern, these are very subtle fractures which can be very disabling. So identifying these fractures and treating appropriately will have a very gratifying outcome. So this paper again by Lucas et al. Have shown that there is 4% of proximal tibia fracture which are associated with dislocations. The timely identifying these fractures and intervening them can prevent a disastrous outcome. So if you see why we need arthroscopic assisted fixation. So these are certain fractures. If you see, they are subtle proximal tibia fractures where if you have not treated them appropriately, they present to us with these kind of instabilities. This is again, if you see, it is a very subtle fracture where there is a medial condyle fracture, cruciates, bicruciate avulsion injuries are there, and there definitely there is some collateral injury as well. So this looks a very innocuous fracture. If you see, there is just a depression in the posterolateral corner of the tibial plateau. And to address this kind of area isolated, it is very difficult. You have to do a very extensile approach. Again, if you see this kind of fracture, where it is difficult to just give a gratifying outcome by just doing an open reduction and fixation. So these are rim avulsion fractures where you can see the meniscal impalement can be a major concern if you if you just do an open technique. So we have also seen that you very nicely fixed proximal tibia fracture present to us with a significant instability. If you see in this case, there is the tibial sag is there, and this gentleman had both anteroposterior instability. And these are certain cases, they are malunited and they present with a gross instability pattern when they do present with a delay. So we try to do a study where we try to assess the role of arthroscopic assisted fixation, and particularly the avulsion fractures, intra-articular depressions, and those who presented late. And we try to find the correlation between these fracture pattern and the Shatzger type. So we analyzed around 435 cases of tibial plateau fractures at Preeti Hospital, Madurai from 2018 to 2022. And all these patients underwent standard ATLS trauma protocol, and the plain X-rays, radiograph, CT was done. MRI was done in case of rim avulsion fractures. And the most important thing what we do follow is the post-fixation EUA. That is, once you fix the fracture, you do an evaluation under anesthesia, and then you come to know that there is significant collateral or cruciate instability, which can be addressed during the index procedure, or you can take up again this patient. So the grade open injuries and the one with the compartment syndrome were excluded from our study. So where we had 124 cases, out of these 435 were underwent arthroscopic fixation. So of these, around 60 were avulsion fractures, which was combined PCL, ACL and PCL, and around 41 patients, that is 33%, had intra-articular depression who went arthroscopic elevation and fixation. And also we had around 13% of patients who had multi-ligament injury pattern, which were addressed both by open and arthroscopic technique. So we had 7 patients who presented with delayed presentation, where we did arthroscopic assisted osteotomies and also reconstruction procedure in these patients. So around 73% of patients underwent single stage ARF, whereas 27% of patients needed 2-stage procedure. So this is why I stress about the EUA. So if you see, you have nicely fixed the lateral condyle, but you give valgus instability, you can identify that there is significant opening because of the MCL injury. So now we keep an anchor handy. So you just put an anchor and repair the MCL. It gives an really excellent outcome. So how we do it, this is, if you see, this is an case example. There is a posteromedial fragment and there is also an anterior avulsion fragment. This patient had GRAS, valgus instability and anteroposterior instability. So we did an arthroscopy. We took pull-out sutures in the ACL, and we did not fix this before, but we have done all the workup. Now, if you can see here, all my sutures are parked in the portal here. Then I do a posteromedial approach. I fix the fracture. The posteromedial fracture was fixed with the plate, and then I shuttle the suture out in the front and fix it so that I don't damage my arthroscopic bites. So this is how we get good stability after fixation. So this is another case where you can see there was a meniscus impalement in this type 1 Schasger fracture. So we did an arthroscopic assisted repair of these fractures. This is another fracture where you can see the one which I showed you before. It had an posterolateral isolated depression. So these are very difficult. You need to do a Frosch approach or modified Frosch approach to access this area. Whereas by arthroscopy, you can very beautifully visualize these fractures under arthroscopic guidance, and you can just do a very minimal invasive procedure. You can see this is the depression on the posterolateral side. You bring the big pin with your ACL jig, and then you make a gradual tamponade, and you can make the elevation of the depressed fragment, and you can fix either by plate or screw, whatever technique you have. And at the end, you can see that you get a very beautiful elevation, and you don't have to do any big approach for these kind of patients. And these are again kind of very gratifying. You can do a PCL avulsion fixation with this similar approach and also fix them with the screw. And this is another way how you can nicely elevate the depressed fragment under arthroscopic guidance, and you can fix them with whatever device, plate and all. At the same time, you can even address the cruciate avulsions and all. And you can see the cartilage, meniscus, everything in these kind of fractures. So these are very subtle fractures. If you see on the X-ray, it is very difficult to identify, but in the CT, it shows that there is a significant articular depression. And when we do arthroscopy, we can nicely see elevation. And also we did an ACL repair for this gentleman. So this is again that fracture where there was a meniscus impalement. We reduced it by doing arthroscopic, and we also fixed it with a buttress plate. And he's almost like now 6 years, he is doing excellent without any issues. So this is the case which I showed, who presented to us delayed fashion, and you can see this patient had underwent metal exit and both ACL and PCL reconstruction in a single stage. So, and this is almost now 6 years. He is doing great. He has not come back with any kind of problem, though he had some kind of cartilage issues, but at least he has now stability. So this is again this subtle fracture. So we usually wait for a week or two till the effusion, everything comes down. And then you can see that this patient had again similar instability pattern, both anterior, posterior. So you put in the scope, you see whether the collaterals are intact. Then if they are intact, we can just do a pull out repair for these things. And the same technique is followed, and also the fibular head was also fixed in this case. And this patient had good stability. So this is that case which I showed you before, who presented to us. This was the initial X-ray. Then he came to us after 6 weeks. There was subluxation, and there was a sagittal split of the lateral femoral condyle. So we did an arthroscopy for him. We could appreciate the sagittal split here. So we did an rim plate fixation for him, and then we also opened his cruciates and collaterals were reasonably good. And if you see after fixation, he had regained the tibial step, and his stability has drastically improved. And also we are able to do a justification by doing this procedure. So this is another case where you can see this is again a subtle fracture. Just if you see, there is a Sigon fracture here, lateral condyle fracture. He presented to us after 3 weeks. So we could see that there is a drive-through sign of the medial compartment. And so here the ACL was completely gone. So I did an ACL reconstruction for him. So if you see, I made the tunnels, I fixed the lateral condyle with a plate. We are just leaving the anterior holes, and then the MCL was completely torn. So we did an MCL repair also for him. And you can see this is the reconstruction we have done, not the repair of the cruciate. So reconstruction of ACL, a repair of the MCL, the drive-through sign has reduced, and also fixed the fracture with a small plate. And this is the stability what he gains after the fixation and reconstruction. And the rehab is very important. We have to put them on a very vigorous rehab as early as possible. This is another paper published where we have done bicruciate ligament repair in long bone fractures in a similar fashion. And this is again our very old paper where we compared the various association of PCL injuries in these kind of fractures which were addressed. So these are chronic situation. When they come with malunited fractures, they have a lot of so we have to do something more here. We do slope correction osteotomy. I did an slope correction osteotomy with the ACL reconstruction for this gentleman. So because he has instability, so he is almost now 6 years, 5 years follow, 4 years follow. He's doing good. So this is a very interesting case. A young chap. If you see, he had a floating knee injury where the femur was fixed and the implant was removed, and there is a shift of the line, joint line, and there was an increased slope, and he was having this kind of varus thirst gait, and he was doing this kind of trick movement. So we did a posterior diagnostic arthroscopy. His ACL PCL was intact. It was only stretched, and there was some cartilage fraying. So you can see that both meniscus were looking okay. But the thing was, the slope, we needed to correct the slope. So we did a posterior slope correcting osteotomy where we put bone graft and small plate, and then later once the osteotomy healed, we removed the plate. He had mild posterolateral instability, and during that stage I added a Larsen procedure for him. And you can see that this young chap, he is doing all kind of activity. He lost all that kind of trick movement, and he has a good stability also. So Cross has described open fracturoscopy where he put the scope through the fracture site, and he assesses the fracture pattern also, which can help in treating these kind of fractures. So there is literature which says that definitely there is an better outcome when we use an arthroscope. So in our study, we had a significant number of type 2 and type 3 Schasger, which had associated instability. And you can see the various pattern of instability also in our studies we analyzed. And the excellent outcome was seen because of this kind of intervention where we address the both cruciates and collateral injuries. So we also had few complications. The delayed union was there because of the fracture pattern. The recurrent instability was there in 6 cases where the quality of the cruciates are very poor. So we had superficial infection, knee stiffness, and which is the part and parcel of the fracture pattern. So we had no compartment syndrome. That is very important because of the appropriate technique and I don't ever use any pump. I use gravity method. You have to be patient, use proper lavage, and then you can avoid the and also the meniscus. So the disadvantage, you have the learning curve, the hematoma can obstruct the vision. It can be a very problem. So you have the fluid leakage, which can cause a compartment syndrome, and there can be other issues. So arthroscopic assisted fixation is a way to look forward in the proximal tibia fractures and also in the chronic fractures who present with disabling deformities. Thank you for your patience, Lynn.
Thank you, Prahalad sir. It was an excellent demonstration of arthroscopy along with the tibia fractures. Can I ask you one question, sir?
Please, please.
Yeah. Are you doing arthroscopy for all proximal tibia fractures?
No. I'm not doing arthroscopy for all fractures. So it is only just how do I unshare my screen?
Unshared, sir. Already unshared.
Okay, great. So I was trying to do that. Okay. So we don't do fixation arthroscopy for all the cases. So it is a pre-op diagnosis and intra-op diagnosis. So if you feel there is an avulsion fracture on the pre-op CT, so then we always keep that in mind that he may need kind of arthroscopic intervention. And once you do a fixation, and then you check the stability. If there is an instability, so then again we think that he may need kind of arthroscopic intervention.
What we find is after fracture fixation, 80% or maybe more than that won't have any instability. Otherwise, other than that, any MCL, as you told in grade 2 and grade 3, if there is other than that, we won't see any instability like ACL and PCL. Only it is more beneficial in rest of the 10 to 15% of the people, I think so.
So if you see in our study also, we had 425 cases, of which
Yes,
we
sir.
have only 124 cases we have done scopy. So it comes
Yes, sir.
around 30%, 20-30%.
Yeah, 30%. Okay, and I would like to ask that question. Anyhow, you have mentioned there is no chances in your study, there are no compartment syndrome, but following a arthroscopy along with fracture, if it is in a type 5 or type 6 high velocity injuries, there is a high chances of compartment syndrome in such patients. How do you deal with that, sir? Following a fracture fixation, you will avoid closure of fascia and any other precautions you will follow.
See, the important thing is in type 5 and type 6, I don't do it in the stage 1. So if you have seen around 20% of cases, we have done stage 2. So
Okay.
you do a fixation, you some time, a week or two for the things to settle. Then again, you can take up for a arthroscopic fixation. Never try it in the single stage. That can be a major concerns. So one more thing, whenever you are doing this, you ask your fellow, your assistant to always keep a watch on the calf. So whenever there is any pressure in the calf, just abandon the procedure, just open it and just leave it alone. So that is very important to always be watchful during your procedure.
Okay, sir.
Thank you, sir.
Thank you, Naresh. Thank you, Amarnath.
Thank you.
Thank you, sir. Can I proceed with the next one, Naresh?
Yes, Amarnath. Please go ahead.
Yeah. Now coming to the today topic expert talk by Dr. Pradeep Nemade sir regarding his techniques, tips and tricks of mini open rotator cuff repair. Now I would like to ask Dr. Pradeep sir to join.
Hi, my screen visible?
Yes, sir.
sir.
Yes, sir.
Yes, it is visible.
So sorry for the delay. Mini open or open rotator cuff repair, my technique. So my gratitude towards my teacher from whom I learned the initials of this technique and of mini open rotator cuff repair, and then we try to do some modifications and try to develop own technique which is kind of more cost effective in this scenario. So this is what is the aphorism goes: ability to perform a technique is not the indication to perform on a patient. Just because we are well versed with doing so many techniques and which appeals a lot doesn't mean that that is the indication or that is the gold standard. What we choose, once we want to choose one technique or other, the one which gives better results should always be chosen, right? So there is no question about that. But if two techniques give similar result, then the one which is simple, one which is effective, and one which is cost effective should be chosen than a complex one. So we know that a rotator cuff repair can be done arthroscopic and open or mini open both, and both can be good or bad. And we should focus on doing a good repair rather than be very fanatic about what approach we're going to take for that kind of a repair. So proposed advantage of arthroscopy is like better outcome, less post-operative pain, lesser stiffness, and cost effective. And we have lot of data which show that there is a similar outcome. Again, no difference. Arthroscopy versus mini open, no difference. Do not, again, no difference. As far as outcome is considered, there is no difference in arthroscopic versus open or mini open kind of a repair. What about early phase pain? Again, early phase pain, there is no difference. Again, equivalent clinical outcome, there is no difference. And all these are randomized control trial or RCTs or the meta-analysis. Again, stiffness, there is no cases of stiffness in mini open, and there is no case of deltoid damage. Again, cost, significantly less cost with a mini open or open kind of a time, and less expensive. So again, arthroscopic have same result but more cost. As far as cosmesis is concerned, look at this. Hardly the scar is hardly any visible, and again, most of the patients are old, and they are not this kind of patient who kind of exposes their shoulder. So again, cosmesis is not an issue. So good rotator cuff repair depends on a good creating a good anatomy and good biology at the rotator cuff level. So again, it is worth reiterating this slide that when we are going to repair, we need to get it a good repair of anatomy and biology rather than be fanatic about what approach we are going to take. So arthroscopic is technically demanding. It takes more time. It's higher learning curve. Again, it is instrumentation dependent, can add to expense. And again, it is implant dependent as well. We need to use specific implants. Mini open technique is the one which I prefer, and my indication is decrease whenever I want to decrease the surgical time and anesthesia time. That is age, poor general health, patient has economical issues, and I would want to do it with for supraspinatus, supra plus infra, or superior subscap, and even entire subscap can be dealt with this. So previously we used to take a longitudinal incision at the mid acromion level, but that is not the good way to go. It the best way is to either take a horizontal incision at the acromial lateral edge, just at the anterior margin along the Langer's line, which is much more cosmetically effective, or just like that, or we can take a vertical incision like this. So this is the acromion posterior angle, anterior angle. So we can follow the anterior clavicular line and take a vertical incision along that. That is also another way of doing, and that is what is my preferred technique nowadays. The axillary nerve is way below at around 6 centimeter when we are taking incision at the anterior angle. So it is much below than what is required deltoid split for our rotator cuff repair. So after taking an incision, we infiltrate with the adrenaline to decrease the blood loss, then and get a bloodless field. We split the skin and subcutaneous tissue along with the line of incision. Then we expose the deltoid, and then we can take either a T-shaped incision on a deltoid, or we can just do a vertical slit. So first we start with a vertical slit like that. So this is the deltoid. We follow the anterior margin like that, and just do a vertical slit. We can have option of going little posterior or little anteriorly. After that, we do acromioplasty by taking off the anterior margin of the acromion, and that is straight in front of you. In 5 minutes, we can do. Many a time I would reserve this for the end of the procedure, because that can cause some bleeding and can cause visualization issues. So sometimes I would try to reserve it for the last. Only when it is too stenosed and not able to see, we want to do it early in the beginning. Then we can do bursectomy, remove the bursa, or we can just split the bursa and swipe it anteriorly and posteriorly and preserve the bursa in that case. So this is the bursectomy. After that, we expose the cuff. That is pretty straightforward below this thing, and we can identify what is the appearance of that cuff. Is it a reverse L shape, or T shape, or a L shaped tear? To do that, we need to put stitches on these 3 points A, B, and C, and try to see how these 3 points can be detected towards the footprint. And then if we can pull the point C towards A, then it is reverse L. If we can pull A towards C, then it is L shape. And if both can be pulled toward the footprint equally, then it is T kind of a tear. And this is how we study the anatomy. And studying the anatomy is extremely easy, because we get full panoramic view, and we can study the anatomy of the cuff much more better, because we are looking from we can get you a very high bird's view. Then after that, we put an anchor. So look at this tear, which is a T-shaped tear. The previous one was a L-shaped tear. This one is a T-shaped tear, and it is easily right in front of your eyes, and we can see the cuff tear very beautifully. Again, we can see another this thing. So here we can see that this tear morphology, we put as traction stitches, and we can see how it is coming. So this is the tear. My grasper is holding it, and we can easily see even the lamellated tears can be seen very easily. That the biceps, that is superior, which we are holding, and then that is the tear, and we can see even the lamellated tear can be seen very well. After that, we do a removal of the sclerotic bone, the top right angle margin of the GT. We do not want to decorticate the GT, just the impinge reactive new bone formation is removed. We can use RASP. We can create microfractures, the Crimson Dewey, and rounding of the GT, the so-called reverse subacromial decompression. After that, we have various repair techniques, either transosseous single row or double repair. What I use is a modified double row technique. Is a combination of a medial row suture anchor and lateral horizontal transosseous tunnel for the lateral row. So after exposing the cuff and everything, the step 1 would be to expose the cuff properly, like that. Place the holding stitches. Step 2 is put the medial row anchor just like what you are using it. Many times we want to medialize this thing if there is a tendon loss, or we can put it normal at the cartilage and bone margin. Either it can be a double row or a double loaded or triple loaded anchor. Once that has been done, we reduce the cuff, and then we pass the suture strategically at the reduced position. So this is one of the greatest advantage of this technique, because in arthroscopic technique, we just pass the sutures as it is. But here we can reduce the cuff. In fact, we can take a temporary vicryl stitch also in reduced position, and then we can strategically pass so that we do not cause undue tension on the rotator cuff tendon if the suture is passed non-strategically at non-anatomical position. So this is how we pass the sutures. So this is a triple loaded anchor, and we have passed 3 pairs of anchors to that. Then once we are done, we just cross the stitches, just like for creating either a speed bridge or a suture bridge. That's how we cross the stitch. And then we create a horizontal transosseous tunnel at a distal level, lateral along the lateral margin of the bicipital groove. The advantage of this is that the bone stock at the bicipital groove is very good. The suture doesn't tend to cut, and more distal you go, better is the bone stock. So this is much better than a vertical transosseous tunnel, because vertical transosseous tunnel, the integrity of the tunnel still depend on the poor bone, osteoporotic bone at the GT, here we can, if the bone stock is not good, we can go even distal and still get a very good kind of the tunnel. Then we can retrieve the posterior sutures of the crisscross anteriorly and tie them with their fellow suture to create a footprint repair, so-called this speed bridge technique, or if we tie them medially and then cross it, it's a suture bridge technique. And this is what is the end picture that we get at the end, the crisscross. And the closure is pretty simple. We can just close the deltoid and put some stitches. So I'm going to present a small video. So this is the rotator cuff tendon. We can see that this is a massive kind of a tear which is retracted. We put the patient in a lateral position. So that is the anterior 1/3, posterior to middle 2/3, and the posterior to 1/3 of the deltoid. So we take a incision that is 1 finger breadth above the anterior margin and 2 finger breadths below the anterior margin of the acromion. Take a straight incision, and then we split the deltoid along this anterior fiber, just like that. This is the raphe that can be seen. So we split the deltoid along the anterior margin. We just cut the fascia with the scissor, and then we can just simply split with the deltoid, and with the artery we can split the fiber. So it's extremely traumatic thing. And then we split the we put a self-retaining retractor, and underneath that we can see that there is a bursa. That's how we split the deltoid. If required, you can take off the deltoid from the anterior margin of the acromion. So these are the traumatic retractors which we put. So we, as I said, we can take off some of the deltoid from the anterior margin of the acromion. Then we expose the we create a subdeltoid space. So we take a wet gauze piece and try to put it underneath the deltoid from all sides to create a subdeltoid space like that. Again, we do not burn any tissue, just like with the RF or something. It is just creating a space by simple dissection. Then we do a subacromial bursa split. Again, we do not need to take off the bursa. You can just take a vertical incision on the bursa, go as distal as possible, and just swipe these 2 layers anteriorly and posteriorly. And now my self-retaining go underneath the bursa. Once that has been done, we can see that there is a massive rotator cuff tear underneath. We can see the bald GT and a reactive bone formation. Then we can pass the traction stitches and try to judge what is the morphology of the cuff tear. Now in this case, I was finding it like a T-shaped morphology. This is the T-shaped morphology. So my A point and C point are coming together and covering the entire footprint. So it's a T-shaped morphology. So in this case, the bicep was inflamed. So I'm doing a bicep tenotomy. The proximal end of the bicep can be incorporated in the repair as the bicep SCR. Again, we round off the GT with either speed burr or a very fine nibbler. So only the reactive bone needs to be removed. We do not want to decorticate it. So we are just removing the rounded right angle part of the GT, not where the cuff inserts. Then we pass the anchor. So that is the anchor that is going at the cuff margin, at the margin of the articular cartilage. Sometimes we want to take off some part of the articular cartilage just to medialize the cuff, as we are doing here for this anchor, especially if we see that there is a excessive tension on this thing. Then we again pass strategically. We hold with the stay sutures and take strategic passage of the sutures. Same way with the this thing, and then here we are incorporating the biceps also. So one stitch go through the bicep and stem will go through the cuff. So when we repair, it automatically get incorporated into the repair. So now that is the bicep, and same sutures we are passing to the cuff. It is very, very simple procedure and very fast. It doesn't take much of a time because everything is right in front of you. And now we are trying the so-called interference stitch, and that also going to incorporate the proximal part of the biceps. And now we have tied the medial row repair, So there's a medial row repair, and now we are around 4 to 5 pairs of sutures down there. Now we develop a horizontal transverse tunnel through the lateral margin. We make a small K-wire hole, and through which we pass the ethibond. Ethibond needle is very thick; it can pierce to the bone. And then we cause this suture in suture technique. So take a 5 number ethibond and the crisscross suture can be easily retrieved through this Ethibond suture, because Ethibond suture is soft suture. We can pass the suture through that, and you can easily use it as a suture shuttle and kind of retrieve all these sutures from posterior to anterior aspect. Once that has been done, we tie again them with their fellow sutures. And then that's how we are tying with using the knot pusher. And this in the end creates a double row effect. So that's the double row effect. And the entire cuff has been repaired only with 2 medial row anchors. Laterally, we do not require any implant, and still we can get a very good double row repair. In the end, we can convert, we can do acromioplasty. So I sometimes do it in the end. So the advantage of this is we can even preserve the periosteum of the acromion from inside. So we don't need to burn the periosteum. We can elevate the periosteum and just remove the bone, the anterior bone and some part of the inferior bone. And we can demonstrate right away that the cuff is not impinging because it is not done under traction. Then we close the bursa. So this is a lot of literature on preservation of the bursa because it gives vascularity. So that's how we have done complete bursa repair. So just like this, and then we do a deltoid closure simple, and then we close the wound. So that is regarding this thing. So sometimes we get massive cuff repair tear also. So those also can be very well sutured. So look at this. This is a very massive cuff repair. Massive tear. We can see the entire humerus is bald. Supra and infra is totally gone. And we can get a very nice repair with such a small incision, because the humeral head can be rotated and entire part of the humeral head can be brought below the incision. So you do not need to do a very big kind of incision. And lateral row, we don't require lateral row anchor because lateral humeral bone is good. That's how we get a medial row anchor and a lateral transversus tunnel. That's how the results. Now we can even do this anchorless configuration like this. This is a Kuroda technique. We can very easily get that done. No anchor required. We can get it done very easily here. Again, if your cuff is retracted, we can very easily do medialization. That also can be done. Subscap tear. Often it is asked, how will you deal with the subscap tear? The subscap tear is very easy to deal with by mini open approach, because the entire subscap footprint can be brought below your width. So this is the tear. We can see it's a very massive tear. Supra, part of infra, and entire subscap was gone. So this is the tear we are looking from the top end. And these are my traction sutures in the supra. So this is the supra. The part of infra is intact. And then this is the part of the infra. And then when we try to see anterior and external rotate, we can see the entire LT is bald. So there is no kind of subscap that is attached, and the entire subscap was retracted. And with these sutures, I try to get the subscap right in the vision, and we can very easily kind of bring this subscap to its footprint. And we can see the anchor placement is so easy, because once we external rotate, the LT comes right in front of you. So we all struggle of putting subscap anchor has gone. It is right in front of your eyes. We can pass subscap anchors. And then we can pass the stitches. So these are the stitches to the subscap. So 2 anchors, 4 pairs. And then again, we can kind of crisscross them, tie medially, and develop a tunnel, and we can get a very good kind of a repair with crisscrossing, and completely entire subscap and supra can be very easily done by this technique. So open or mini open cuff repair is very simple. It allows anatomical repair. It is extremely cost effective, and deltoid splitting is not at all morbid. To improve the ease of surgery, you can use arthroscopy instruments and suture shuttling device. This is a small video which kind of encapsulates the entire philosophy.
लेती थी कि वही महंगे दामों वाली क्वालिटी, वही सफेदी, वही झाग, कम दामों में मिले तो कोई ये क्यों ले, वो न ले।
मान गए
इसे
आपकी पार की लत।
आपकी पार की नजर और मी ओपन सुपर दोनों को। थैंक यू।
Thank you, Pradeep sir. It was an excellent demonstration of mini open rotator cuff repair, and we usually do in large rotator cuff tears, which includes supraspinatus as well as posterior aspect of the infraspinatus. In some cases, subscapularis as well.
Yeah.
You told no. Usually we take anterolateral corner to vertical incision.
Yeah.
You told there is a late transverse incision.
Yes. Yes.
In transverse incision, are we damaging the deltoid at the?
No. Only the skin incision is transverse. The deltoid incision is vertical.
Vertical. Yeah. Usually will go through the raphe.
Yeah, because the horizontal incision, transverse incision, is parallel to the Langer's line,
Okay.
and it is much more cosmetic once we suture it.
Okay.
That thing. So that incision is prepared for a smaller tear. So you take the transverse incision, develop a subcutaneous kind of a dissection, and then take kind of retract it so that the incision becomes more kind of an oval or circular, and through that circular you would split the deltoid vertical. Now the entire window can be slide up and down if you are so fanatic about length of the incision. So the entire window can be split up and down to get the good split of the deltoid.
And one more thing, sir. During anterior raphe will be there, no deltoid raphe. Once we split it, and we will erase some part of the deltoid from the acromion as well. And finally, what we do is, after doing acromioplasty, we will repair to that bone.
We can
that
repair
which part we erase from that.
So it need not be repaired to the bone. We can just do fascia closure.
Okay.
We can just do fascia closure because anterior bone anyway we are removing, because you see the any bone that is anterior to the anterior margin of the clavicle is not needed.
Okay.
So we can safely remove that bone. When you say acromioplasty, it is mainly the anterior bone, not the inferior bone.
Yeah, anterolateral mostly, anterior.
So that bone is anyway removed. When we are repairing, we can just repair the fascia. We do not need to pass it through the bone. So the deltotrapezial fascia on the lateral side and the fascia on the anterior side can easily be repaired.
Okay. Even though when we pass the one Vicryl needle, it will easily pass us through the
Very
acromion.
easily,
Why? Because we will be shaving some part of the under surface and that thing.
Correct.
We can do that thing also, sir.
Correct.
And as you told, it is a very cost effective. It is a very
cost effective. You can do,
and it is very fastly done. Maybe hardly 45 minutes to 1 hour if it is a regular rotator
simple tear can be done within half an hour. If there's larger tear, then it takes some.
Okay. How would you deal in osteoporotic bones and subchondral cyst bones, sir?
So
in mini open.
So osteoporotic bone, when your anchor is not holding like that, so you can always use the technique which you are showed by Dr. Kuroda. Like you can drill those 3 vertical kind of the tunnel. You can take the sutures like this kind of a staple there and tie it distally. So you are not now dependent on the vertical kind of the suture configuration. Your main hold is on the lateral and inferior part of the bone, and those 2 sutures are coming like a staple from up. And in addition, you can add those 2 vertical this thing to create a double row effect. So that is one technique which I found very useful. Or you can just use the simple transosseous also as well if you want to get. Many a times if you see, we can even the bone of the GT is osteoporotic. If you medialize the cuff tear by taking off, let's say 8 millimeter of cartilage, then that bone is very good for the anchor holdage.
Okay. Some people will be having subchondral cyst in the GT area.
GT, yeah. If you can locate it easily, like that is right in the front of you.
Yeah.
So with the image, if you can like map that cyst, you can even curate that cyst if at all it is required. It's called a geode. You can just easily curate that out.
And regarding the post-op stiffness, in mini open, we find somewhat more stiffness when compared to arthroscopy. That is reduced by doing a proper subchondral decompression. This one.
No. I rather kind of disagree with this notion. because of 2 to 3 things I would like to put. Number one is that since the cuff repair is directly under your vision, that is number one. You are so kind of confident about the repair.
Yeah, definitely we are
That
more confident,
I
yeah.
start range of motion as early as possible. I do not immobilize this patient at all. That is
Yeah,
number
we
one.
will also follow the same.
Number two is that arthroscopy we do in a kind of abducted position, and the open repair we do it kind of adducted position because we want to bring the GT out. Now, when we repair, the cuff is at whatever tension is during the repair. Afterwards, it's not. Rather, in arthroscopy, when you do abducted, we repair. At that time, it is lax, but when the patient brings it, it is under more tension. So, post-op tension on the repair is not an issue with the open repair, because whatever tension is there, that is the final. No more tension can be done after that. So, because of these 2 points, we can mobilize them as early as possible. So, I would rather start just with after 2 to 3 days external rotation in adducted position. That is the first thing. And even the passive, so I don't give shoulder immobilizer, I give elbow pouch, normal elbow pouch. So elbow pouch will do some kind of gravity elimination, and with gravity eliminate position, patient can do all activities, all the range of motion possible, like gliding the humerus front, back, remove the hand and do external rotation. So that will not prevent any, that will prevent any kind of adhesion. Now, second thing, where would adhesion develop? Adhesions will develop where we are violating the normal loose areolar tissue, right? Where will the adhesion develop? Now, the surgical footprint. Even in arthroscopy, we are violating entire subdeltoid space. Rather, we are burning with the RF, right? We are shaving off. So subdeltoid dissection is same with arthroscopic or mini open. That is not a problem at all. The intradeltoid dissection, rather than having 3 8 millimeter to 1 centimeter holes, we have one continuous 4 millimeter split. And that does not cause any kind of stiffness. We know we are doing nailings, we are doing big proximal humerus surgery or the RTSA, and our patients do not develop stiffness because of the intradeltoid dissection, right? So intradeltoid muscle split does not cause stiffness. Subdeltoid adhesions is same with arthroscopic or mini.
Any more questions from the panel, please? Sir, there is a question in the YouTube chat by Dr. Muzammil. He was asking whether when there is a massively retracted subscapular tear, it will be difficult to visualize. How do you do about that?
Absolutely not at all, because it is rightly in front of you. The moment you retract the deltoid anteriorly, it is right in front of you. Subscap is not at all an issue. Rather, subscap is more easy than supraspinatus to visualize and repair, because it is right in front of you.
Yes.
The subscap is a problem with arthroscopy. Subscap is not at all a problem with mini open, because it is right in front of you. This I showed a video, right? The
Yes,
anchor
yes.
placement is much more easier than the supraspinatus. The issue is that if you are taking a mid-deltoid incision, mid-deltoid, then there can be issue. So we do not want to go mid-deltoid. We want to go anterior 1/3 and posterior 2/3. Now the advantage of this incision, you can go up as much as you want. Even if it is the AC joint, you can go way up to the AC joint, way up to the clavicle. Does not matter. Does not matter. So if at all you are facing that problem, which you should not, you can always increase the incision, deltoid split up, and everything will be right in front of you.
Thank you, sir. One more question for Dr. Prahlad, sir.
Naresh.
Sir, can arthroscopic elevation of the tibial plateau can be done in presence of intramedullary nailing in a two-week-old fracture? That was a question.
Yeah. Definitely you can do. See, your intramedullary nailing entry is not at all has to do anything with your scope, no? So only thing is when you are putting the jig and all, you have to make sure that the nail doesn't come in your way when you are tamping. So you have to make sure that it doesn't come in the way when you are tamping. So you have to do some changes in keeping your jig so that your nail doesn't come in the way of your tamping.
One more question, sir. Whether in case of fixation of the tibial plateau, arthroscopy first or fixation first?
See, in subtle fractures, rim avulsion fractures, I do arthroscopy first. But as I discussed before, type 5, type 6, it is always fixation first. Even in first 3 types, whenever there is just lateral condyle, I do fixation first. Avulsions, we can do it after fixation. So plan accordingly. So if they are just do a fixation, if there is instability, then we can take up the scopy. But as I told again, if there is an avulsion fracture, I always do a scopy, secure the avulsion, then do a fixation, and then fix the avulsions, so that our avulsion sutures doesn't get damaged when we are putting the plate or screw.
Thank you, sir.
Thank you.
Dr. Amarnath, if there are any more questions, we can close.
Yeah, it's okay. Nothing.
Thank you everyone for joining this February month academic corner. As usual, this was a very learning experience for everyone. I would like to thank Pradeep sir for and Prahlad sir for accepting this at the last minute and making this continuity in a succession. Thank you very much. Thank you, Raghavendra sir, Amarnath, and Pradmesh sir for wonderful moderation. Thank you, everyone. Bye. Good
Thank
night.
you.
Thank you, sir.
Good night.
Thank you. Thank you. Bye.
Good night, sir.
Bye.
Bye.